Okay, guys, let's, so I don't have to stretch my voice anymore, let's stop talking, okay? Please. Okay. All right, we're going to get going. All right, we're going to talk about Strep pneumoniae and Staphylococci. All right. Again, these are gram-positives today, so ignore the colour scheme. It's nothing, in that sense, it's got nothing to do with whether they're gram-negative or gram-positive. We're going to talk about Streptococcus pneumoniae, and we're going to talk about Staphylococcus aureus. And you'll note that says Staph aureus, and Staph epidermidis is right down the bottom there, and it doesn't say anything about it. The big deal here, that's not quite true. Streptococcus pneumoniae, as I've mentioned already, is one of the major killers in this world, bacterial killers. Staphylococcus aureus is an opportunist that's found in anybody's skin, and it could be Staph aureus and it could be Staphylococcus epidermidis. Staphylococcus epidermidis is less pathogenic than Staph aureus, and it produces a lot less pathogenesis factors, and so what we know an awful lot about these pathogenesis factors in Staph aureus. There isn't much in Staphylococcus epidermidis, and what we say about Staphylococcus epidermidis is not we ignore it, we contrast it to Staphylococcus aureus, and that's what I will do when we get to that point of the lecture. Okay? So we're going to be focusing on Streptococcus pneumoniae and Staphylococcus aureus with a little bit about epidermidis and so on, so little I didn't even put it down there, Staphylococcus saprophyticus. It's in the handout though. Okay, again, this slide I showed you earlier, this is a Diplococcus, the pneumococcus. That important. We don't give names to things like that unless it's really important. The pneumococcus, the meningococcus. You know, we don't use names like this unless they're sort of really important. The gonococcus. All right, this is the pneumococcus. Streptococcus pneumoniae is the leading cause of pneumonia. And yes, a septicemia and a meningitis is worse, but a pneumonia, of course, is life-threatening. Particularly the young and the old. Presumably, in the young, the immune response hasn't developed that well yet. And in the old people often, the immune system starts to wane. The immune system is very important in protecting against an infection with the pneumococcus. The pneumococcus is, like many other of these bacterial pathogens, not all of them, but like many pathogens, is found in the normal flora. But it doesn't do an awful lot most of the time, unless you happen to get unlucky and you have a prior viral infection. This can cause damage to the respiratory tract and cause antigens and surfaces that were not normally exposed to be exposed. In that situation, the pneumococcus ends up where it shouldn't, and it can start to grow and invade. And it does, gets into forming a bacteremia, and then it can get from the bloodstream into the brain. Middle ear infections are also common. Many people who've had young children in this room will know that they've had their kids treated for ear infections. Haemophilus is another one. But Streptococcus pneumoniae is also a major cause of middle ear infections. Now, again, whether we consider this thing as a Streptococcus, it used to be called Diplococcus pneumoniae, I think, at one point, but regardless whether or not, it looks, under the gram stain, you could confuse a gram-positive paracocci with Streptococci, which sometimes the chains are very short, or sometimes they are actually, some of the strains actually do appear as Diplococci. So we can confuse the Streptococcus if we just did a gram stain. It helps knowing the fact that it's alpha hemolytic. This instance, the pneumolysine, which degrades red blood cells under aerobic conditions, as opposed to the hemolysins I mentioned earlier, are involved in this hemolysis. Like other Streptococci, it grows well on sheep blood agar. There is no group antigen, no carbohydrate antigen. So that means that what we talked about, the two possible schemes, one involving hemolysis and a grouping antibody, or one involving hemolysis and a biochemical test, cannot possibly apply to the antibody aspect. The grouping cannot apply to the pneumococcus because there is no group antigen, period. Diagnosis. If you've got, as I say, you are very concerned about the possibility of somebody having a meningitis in this disease, direct gram staining or detection of capsular antigens, if it works, can be very useful. And again, if you don't find anything, that doesn't mean that the person doesn't have meningitis or doesn't have pneumococcal meningitis. You care about the positive result. If you get a positive, you know what's going on. You know how to treat it. If you get a negative, well, you're unlucky. You don't just give up on the patient, okay? So these things, as I mentioned before, direct stains are not as sensitive, and nor are nothing is as sensitive as culture. But it will take a day or two for this organism to grow up, and you're not going to sit there and say, well, my patient's dying. I'll get a result back from the clinical lab in a couple of days' time, so let them just sit there and hopefully they won't die in the next 48 hours. No, of course not. You go ahead and treat, and hopefully while you're treating, that'll be the end of it. But if not, the organism has grown up, and it will help you proceed to do the treatment if you have to proceed. Okay, now I've mentioned autolysins. This is the organism that we talk in general about autolysins when we talk about the use of antibiotics and cell wall biosynthesis and degradation. But particularly, this organism has one of the most potent autolysins. And it has been studied quite extensively. And this is my attempt to explain the situation, because every textbook I've ever read seems to be totally confusing. So this may not be 100% accurate, but at least it's the best I can do to explain the situation. All right. My representation of what's going on is as follows. Lipoteichoic acids, as you know already, are found in cell membranes. Teichoic acids, on the other hand, are covalently bound to cell walls. This is a particular teichoic acid that has choline as a component. In this instance, we would assume that in a normal situation, the autolysin would be bound within the cell membrane and could not get at the cell wall. However, if for some reason and remember, this autolysin actually binds to both teichoic and lipoteichoic acids. So, if for some reason this autolysin is released from the lipoteichoic acid, what's going to happen next is that instead of the autolysin being in the membrane, it's going to be in the wall. And what that means is it's going to chew up the peptidoglycan. And that's exactly what happens. These bacteria dissolve. And it's been suggested that, and in fact not suggested, it's been shown experimentally, that antibiotics will result in the damage to the cell. And as a consequence, this process actually happens. So it's believed that antibiotics actually act synergistically in this instance with the autolysin. The antibiotics leading to release of the autolysin, which can then finish the job. And these things do dissolve. I mean, they really dissolve. When you've ever seen a pneumococcal culture, I mean, they can dissolve in front of your eyes. And it's part of the test as well, because it's so potent. Let's see if I've got that one down here. Well, this is not the stomach we're talking about. This is a throat infection. This is a respiratory tract infection. Yeah. We're more talking about what would happen in the bloodstream or in the brain, something like that. Okay, so that's an autolysis. No, this has got nothing to do with. No, don't think about stomach enzymes. No, this has got nothing to do with that whatsoever. Don't even go there. Okay. All right, C polysaccharide. All right, now don't get confused here. Okay, that's what people call it because it's a polysaccharide produced by these organisms, the teichoic acid, in fact. But if you mix this polysaccharide with serum, you get a precipitate. There's a protein in blood called C-reactive protein. It's one of the acute inflammatory mediators. But anyway, this is called C polysaccharide because it reacts with C protein. It's got nothing to do with grouping sera. It's got nothing to do with group C streptococci. Okay, so just because you see C, don't say, oh, it's a group C streptococcus. It is not a group C streptococcus. Okay. Identification. All right. I've shown you some thumbnail sketches that I've drawn before, showing you MICs and Kirby Bowers sort of ways of doing sort of antibiotic susceptibility testing. This is not used for antibiotic susceptibility testing. This is used for identification of the pneumococcus, but it's the same principle. You take a little disc that in this case has got the chemical optocin on it. If the strain is not sensitive to optocin, that means that it will grow quite happily right up to where the disc is with the chemical optocin in it. If it's optocin sensitive, on the other hand, around the disc you will see that the colonies don't grow. Okay, so this is a test for Optochin, this is a test for this organism being optochin sensitive. It's not a how did I put it here? No. Anyway, it's a test for the organism. It's a test for what it is. Because remember, we can't do grouping. Okay, there's no grouping for this organism. So those are the two things that you would do. First of all, there's a simple test that you can use to detect autolysis. And the second thing is you can look for optochin sensitivity, and that is in the handout. Okay, I just want to show you the pictures here so you can. I think sometimes it's nice to sort of see the pictures, get the big picture, and then read the stuff afterwards. That's what my recommendation is. Okay, so that's optochin sensitivity. The capsule in this disease is extremely important. It is a major pathogenesis determinant, and indeed the vaccine that we have, which is used widely for the old and the young, not against for the whole population usually, but for the susceptible individuals, there is a prominent capsule in virulent strains. And surprise, surprise, we know by now that capsules are generally anti-phagocytic. We also know, and we shouldn't have to be memorizing it for this thing, we know that basically the only capsule we're going to come across in medical microbiology that isn't a carbohydrate is the polyglutamic acid of Bacillus anthracis. This case is typical, it's a carbohydrate capsule. It varies in antigenicity among strains. And depending on the year and the decade, there can be, there's dozens and dozens of different capsular antigens. And what the vaccine represents is a mixture of capsular antigens prepared from different strains that hopefully is enough cross-reactivity to pick up any strain. Okay, so the capsule is not only important in pathogenesis, it is important in terms of vaccination. Now, what you'll note is that most of the time, I don't say anything about vaccination with bacterial infections. But the truth of the matter is, there are some diseases we're going to talk about later. We talk about diphtheria, tetanus, that are used in all children, all babies are given vaccination. Most of the time, there aren't vaccines. Even if there aren't vaccines, or if they are vaccines, there's no good reason to use them. In this case, this is used. This is a major major human pathogen, and we do vaccinate against it, usually in susceptible individuals. So again, immunity is serotype specific. The vaccine contains multiple serotypes, and this is an example. I used this word type earlier on. This is a case where we use it. We use the word type when we need to use it. And here it's referred to as serotype, referring to the different antigens that could be present. It's usually used only for the susceptible population. That may be changing. Okay. The Quaylung reaction is a reaction that is used generally to sort of see if you can find the presence of a capsule. In this case, we care a lot if there's a capsule, because that's the major pathogenesis factor in this organism, is the capsule. And again, it's not something that you would do in a routine laboratory, but using antisera, you fix the capsule. The antisera actually fixes and holds the capsule in place. Normally you couldn't see a capsule except under an electron microscope. But in this case, it can make the capsule more fixed and visible, and you can see it under a regular light microscope. And that's referred to as the Quaylung reaction. In addition to the major pathogenesis factor, the capsule, it is believed that the teichoic acid, some say it's the peptidoglycan, but whatever, there is a massive amount of complement activation, and this is a real pussy disease where there's a lot of polymorphonuclear cells that you would find either, for example, in a spinal fluid. So it's believed that the teichoic acid of this organism activates the alternate complement cascade, just like lipopolysaccharide, just like peptidoglycan does. It's believed to have a particularly potent activator of the complement cascade, which causes the infiltration of polymorphonuclear cells to the acute site. Fortunately, Streptococcus pneumoniae most strains are susceptible to penicillin, but resistance is common. And I won't go any further about saying what antibiotics, because it will change from year to year and decade to decade, what the particular antibiotic of the decade is. Okay, that was the pneumococcus. The second biggie, non-groupable. You know by now that it's group A, group B, very rarely group D, almost never C, F or G, and the pneumococcus is not groupable. Now we're going to deal with the Staphylococcus. And I have my thanks again to Dennis Kunkel for this nice picture. Okay, Staphylococci are gram-positive, again, facultative anaerobes. They grow in grape-like clusters. You can see there's clusters here, but yes, if you look, there's some what appear to be diplococci there and there and there. That is not a Diplococcus. The predominant thing that we see in that field are grape-like clusters. They are catalase positive as opposed to Streptococci, which are catalase negative. So again, this is emphasizing the importance of the catalase test in addition to the gram stain, because you can confuse yourself. If you happen to just look at that part of the field, you've got bad luck. Looked over here, you might say, well, I've got a Diplococcus here. Well, no, you don't have a Diplococcus. You have a Staphylococcus. And some strains clump more than other strains. You know, life is like that. They are major components of the normal flora of the skin and the nose. And the one that is definitely the major opportunist, I did say opportunist, and it's one of the major opportunists you see in hospitals, along with gram-negative rods, Streptococci, Enterococci. One of the major opportunists one sees in hospitals is Staphylococcus aureus. One of the commonest opportunists found in hospitals and the community, but particularly thinking about opportunistic infections in hospitals. Pneumonia, you name it, it's got it. Pneumonia, osteomyelitis, septic arthritis, bacteremia, endocarditis, abscesses and boils, skin infections. In the community, you might be seeing a lot of abscesses and boils more. In a hospital situation, you'd be seeing more pneumonia and bacteremias. We should emphasize here, though, not because it's the only thing we see in this disease, because just about any organ of the body could be affected by this, but osteomyelitis and septic arthritis are particularly emphasized in this disease because Staphylococcus aureus is the commonest cause of septic arthritis. For some reason, it seems to lodge in the bone. We also do see Streptococcus epidermidis causing septic arthritis, and also osteomyelitis. But Staph aureus is the one you really think about when you think about septic arthritis and osteomyelitis. And indeed, since things like Neisseria gonorrhoeae, which causes a gram-negative septic arthritis, will usually be seen in a sexually transmitted diseases clinic, whereas something like Staph aureus infection, septic arthritis, would more likely be seen in a rheumatology clinic. So your perspective on life is going to change where you work. Okay? So basically, if you're a rheumatologist, you're going to be very concerned about septic arthritis. Probably not so concerned about it if you work in a sexually diseased clinic, where you'll be more concerned about Neisseria gonorrhoeae, septic arthritis. Food poisoning. Okay, now this is something that's very common. It's part of your differential diagnosis when you're talking about gastrointestinal problems. We emphasized a lot the gram-negative rods earlier. Well, gram-negative rods aren't the only thing that cause gastrointestinal problems. This is not an infection. That's the point. It is not an infection. We talked about infections a lot when we talked about gram-negative rods. This is not an infection. The organism grows up in food. It's typically a situation. Somebody leaves some, is at a picnic somewhere, might leave their food laying out for a few hours, and the organisms, people shed skin all the time, and so they touch the food, or the human skin gets shed onto the food, and Staphylococci grow up. So the food is contaminated by the people. The bacteria grow up in the food, and then they produce an enterotoxin, and the word entero means what it says, specifically a toxin that acts in the gut. So now, fortunately, the onset is quite nasty. Many of you have had, if you think about it, you've had food poisoning caused by Staphylococcus aureus. So I don't need to tell you what it's like. You've had it. And the throwing up and the feeling bad all night and what have you, that's typical of the situation. As you know, you've had it. Onset is very sudden. A few hours after you've eaten, you go to a restaurant somewhere, the food tastes great, you come home, you start throwing up, nausea, vomiting. That's staphylococcal food poisoning. And you feel better next morning because it isn't an infection. Okay? Once the toxin's been chewed up in the stomach, and particularly in the stomach, the disease goes away. Okay? So this is not an infection. Onset and recovery are both quick. Totally different than what we talked about with active infections by the Enterobacteriaceae. Food poisoning. Vomiting, nausea, diarrhea, abdominal pain. Gives you bad memories, doesn't it? Okay, that was probably staphylococcal food poisoning you had. Now, this I put up many years ago, but if you pick up a box of tampons, and at least 50% of the people in the room will be doing that, if you read the insert on the tampons, you will still see that it talks about toxic shock syndrome. It doesn't talk about Clostridia, probably. It talks about toxic shock syndrome. And the reason it talks about toxic shock syndrome is as follows. Usually speaking, I mean, toxic shock was unheard of in this country, anywhere for that matter, until the 80s. And what happened was there was I don't remember the number, it was probably around 100, but there was a fairly large group of women actually didn't just get sick, some of them died from toxic shock syndrome. And it is the classic toxic shock. And what happened was that there was a particular form of tampon on the market called a super tampon. And presumably what happened was that the organisms found this bloody, moist environment very pleasant, and they grew up in the presence of the super tampon. Particularly, there was something special about the Rely tampon. And so once the Rely tampon was withdrawn off the market, which it was very quickly, and the other super tampons that emulated it, Staphylococcus, I'm not saying it's gone totally, it hasn't totally gone, because now that people recognize that it's a disease, people look for it. But essentially the outbreak of toxic shock syndrome was with us, and it was gone. Okay, as with all regulations to do with the government in this country, once something is on the books, it never goes away again. And that's why you'll see the information on the inserts for tampons. But a regular tampon doesn't cause toxic shock syndrome. It's a super tampon, and you'll never use a super tampon because you can't buy super tampons. Okay, so anyway, that's the situation. So but it does occur. We're not going to say it doesn't happen. It could happen. Yeah. Very large and very absorbent. But you can't buy this type of tampon. Okay? It was taken off the market. That's the point. Well, that's part of it too. Yeah, that's part of it too. But regardless, the situation is that it created I think you're right. I think you're absolutely. They were used for longer as well. But this type of tampon is you cannot do this now. It's just illegal because of this situation. Okay, so I agree with you. If you I suppose if we want to get into the gory subject, if you were not to change your tampons very frequently and I'm not an expert on the subject for obvious reasons. Presumably this is a possibility, but it shouldn't. So I'm not saying ignore it. It's gone. It could happen, but you're not going to see the problems that you saw once these objects were removed from the market in the 80s. Okay, toxic shock syndrome. Now, particularly, this is fever, rash, desquamation of the skin, because what happens is the organism stays put in toxic shock. The toxin disseminates. Now, why am I making a big deal? Because after this, years after this, it was recognized, I think I mentioned it actually in the earlier lecture, toxic shock-like syndrome is associated with a few strains of occasionally with Streptococcus. And I mentioned about the fact that Streptococci, the newer strains, could be invasive. So the toxic shock-like disease associated with the group A Streptococcus, some of these invasive bacteremias and myoclonitis and whatever I talked about, they're referring to the fact that it resembles, in some aspects, toxic shock. Okay, because there are two different features of streptococcal disease. One of them is a toxic type disease, like toxic shock, and the other one is myonecrosis. Now, in the case of staphylococcal toxic shock, the organism stays put. It does not invade. Okay, so that's a big difference between the two types, between streptococcal toxic shock-like disease and staphylococcal toxic shock-like disease. In this particular case, you see vomiting and diarrhea when you see it. And I stress it, it's not gone away. I mean, I think, if anything, people are more aware of it. I mean, if it does happen, you'll see it, you'll know it. Toxic shock syndrome. The toxin, I said, disseminates. The organism does not. This is not invasive. Another distinct disease caused by the Staphylococcus, as opposed to the opportunistic infections we talked about initially. The toxic shock is not really an opportunistic disease. It's a distinct entity in its own right. Scalded skin syndrome is another one. Scalded skin syndrome can occur in babies, and it's exactly like it says. The baby looks like it's been boiled in a pot of hot water. The skin sloughs off and is red and sloughing and just ghastly looking. And it's caused by a particular toxin called an exfoliatin, causing exfoliation. That's a particular disease, not very common, but when you see it, you know it. Now, this organism, and I have chosen, it's just a limit what you can do in this life. There are a number of different toxins produced by this organism, and they differ in their ability to what cells they'll kill and what cells they don't. And they're referred to as alpha, beta, gamma, and delta. And I've chosen to pull out two features which I think make these things very characteristic. In this case, it's an enzyme, a sphingomyelinase, which will degrade lipids. I presume that's how that one works. Many toxins are not as well characterized in what they do as we'd like. That one's very clear what it does. And the delta toxin we already mentioned. And the only reason I mention it's important is because it's not an enzyme. It has a detergent-like action. And then there's another one that's referred to as a leukocidin because it specifically acts on leukocytes as opposed to other tissue types. There's probably more detail in Murray. Or if you really want to go into this, get into Zinsser and really go to town. Now the issue is that these things, we don't really know how important they are in pathogenesis. We think they are because the Staphylococcus aureus is so more likely to produce an opportunistic infection than Staphylococcus epidermidis, which doesn't make any of these things. This is an example where I said I'll talk about Staphylococcus epidermidis only being the fact how different it is from Staphylococcus aureus. And, different strains, some can produce some of these toxins, some can produce all of them. It varies among strains. And it seemed very reasonable, although nobody's ever convincingly shown it, that these things are factors in pathogenesis because of the fact that Staphylococcus epidermidis is much a lower incidence in causing opportunistic human diseases and doesn't make any of these things. Okay? Protein A is also emphasized in this disease because it's one of the very, very clear examples of an organism that can actually makes a factor that really, in a very clear, very specific way, inhibits phagocytosis. And I did show this figure before, and I want to emphasize it again, as refers to the Staphylococcus aureus, but not Staphylococcus epidermidis, another feature that's different. Just anything I say about Staphylococcus aureus, you can, and there's more details given in the handout, chances are it's not going to be the case with Staphylococcus epidermidis. Protein A, okay, in this instance the organism makes a thing called protein A, and it binds to the Fc portion of immunoglobulins. And there are actually various weird and wonderful mechanisms you can think of about what protein A might do to inhibit phagocytosis, and I'm just giving you one example here. And in this instance what happens is that the protein A sticks to the Fc receptor, so it can't bind to the Fc receptors of phagocytes. And you may see other possibilities elsewhere. The big deal is that Staphylococcus aureus produces a protein A, it binds to Fc receptors, and it stops interaction with, it binds to the Fc portion of immunoglobulin, and it stops the binding of immunoglobulin to Fc receptors of phagocytes, inhibiting phagocytosis. And that's very clear, very, very well known, very well defined. Okay. Spread. This organism also produces lipases that degrade membranes and hyaluronidase that chews up the hyaluronic acid component of connective tissue. It chews you up. Okay? The myonecrosis would be examples of something much worse than that. And basically what it does, it loosens up the connective tissue and presumably allows the organism to more easily move through the connective tissue. So that's what they're doing there. It's obviously not that nasty because we're covered in Staph aureus, and if this was really, chewing up connective tissue all the time, well, you should basically be bone and muscle at this moment. Okay? But it's a factor once it gets into the connective tissue in spread. Okay, now we're going to again differentiate Staphylococcus aureus. Yeah.
How much does it spread? Because we talked about that the organism itself doesn't. How far does it?
Well, no, that's a good question. I was talking about toxic shock when I said that.
Okay.
Let me answer you. If I didn't give you the answer, you need to give me some more, okay? The situation is that in an opportunistic infection, we have introduced the organism beyond the skin, okay? Or they may have been more ready to get an infection because they're immunocompromised, or maybe we've actually introduced it. For example, if a rheumatologist was taking a sample of synovial fluid, they may well introduce the organism into the joints. It may in some instances spread from the bloodstream. But the issue is it's not just an issue of it just sitting in a normal healthy person. It's not going to do anything. In an opportunistic situation, the organism may well be in the bloodstream or in a tissue or what have you. Now, toxic shock, we're talking about a normal, healthy woman, not somebody who's got an opportunistic infection. It's growing in her normal flora. Okay, and in that situation, the organism will not spread, but it certainly will spread in an opportunistic situation. Okay, does that come? Yeah, I stress, you we're doing this, look at that's a good. No, you raise a good point there because it certainly did sound like a contradiction. When you're looking at the different, when you look at some diseases, it's just one organism, one disease. End of discussion. There are some situations where it's one organism, multiple diseases. Okay, and you've got to make that decision. If it's one organism, multiple diseases, you've got to look at each particular disease and seeing what's going on for that particular disease, with not just the overall situation, okay? Now, there's going to be other examples. When we talk about diphtheria, there's just one way. There's diphtheria is a toxin. That's it. It's a disease. That's all you see. Cholera is that way, okay? But that's not the case with the streptococci and the staphylococci. Okay, and again, just because I emphasize we tend to emphasize where we have to put detail in. That doesn't mean just because we spend more time on it, it makes it more important. We spent more time discussing toxic shock syndrome than we did discussing opportunistic infection. That doesn't mean toxic shock syndrome is more important than opportunistic staphylococcal infections. Not at all. Okay, because staphylococci are one of the most common opportunists that you see in the hospital. Okay, so don't confuse detail necessarily with importance. And don't confuse it with national boards with the real world either. Okay, all right. Let's talk about identification. In identification, we want to specifically differentiate Staphylococcus aureus from Staphylococcus epidermidis. So I'm going to show you two slides which are the exact opposite. First of all, these organisms Staphylococcus aureus is beta hemolytic, which is why you could confuse it with, as I said already, with the group A Streptococcus. In fact, they are really beta hemolytic. I mean, Staphylococcus aureus is even more beta hemolytic than a Streptococcus. They are really beta hemolytic. But they do usually, not always, produce a yellow pigment. The colonies are actually yellow. So if you see a beta hemolytic colony on a plate and it's yellow and it's a Staphylococcus by gram stain, you've got a pretty good idea that it's probably Staph aureus. But not all the colonies are necessarily yellow. The name of the organism is Staph aureus, which means gold-coloured. That's what aureus means. So obviously the typical colour for a Staphylococcus aureus is yellow or gold. But they're not always yellow or gold. And that's why we have to do another test. Basically what you do is you put the organism in a test tube that has some media in it that will be pink in colour. And it contains the sugar mannitol, sugar alcohol mannitol. And what happens is these Staphylococcus aureus will ferment mannitol. If they produce mannitol, there is a pH indicator in the tube. And the pH indicator is pink when it's a neutral pH, and it becomes yellow at acid pH. So the tube changes from pink to yellow. The organism also produces an enzyme called a coagulase. And whether it's got anything to do with disease, your guess is as good as mine. But it's certainly very important in determining whether you've got Staphylococcus aureus infection. The enzyme coagulates plasma, and it forms a clump, and that's what you're seeing here with my thumbnail sketch, a clump of plasma, that plasma that's been coagulated. Okay, I'll show you the next slide. It will be the exact opposite. That's for Staphylococcus epidermidis. Now, in reference laboratories, the thing you think about in typing with the Staphylococcus is phage typing. Why do we think about phage typing with the Staphylococcus? We think about antibody serotyping with the Streptococcus because it just happened that way. Somebody found that there's a lot of phages in the Staphylococcus, and they vary a lot from one strain to another. And it's been shown that if you happen to be probably one or two labs in the country that have the capability to do this anymore, probably I'm sure the CDC does, basically, different phages will recognize different strains of Staphylococci, presumably binding to different surface receptors and what have you. So you can type these things. And why would you want to type them? Well, let's take an example. Let's say you've had, for example, what you think might be an outbreak of toxic shock syndrome. You would assume it's one strain or one type of strain that might be doing it. It would be very useful to you to know that that all the patients had a particular the same strain. If you were in a hospital situation and you found all of a sudden that you were getting a much higher incidence of Staphylococci than you normally had, and you thought, aha, we've got some particularly potent strain of Staphylococcus that may be infecting our patients, we want to know that it's really that they're being reinfected, that it's not an issue that they're constantly being brought in from the outside. That's where typing comes in. That's why you need something like phage typing. Epidemiology is what it's referred to. Public health people love that terminology. Epidemiology. Okay. Sorry, somebody said something? Okay. It's the nice thing about the microphone is you can drown people out, you know. Okay. Staphylococcus epidermidis. In total contrast to Staph aureus. Again, it's a major member of the normal skin flora. I haven't attempted to even give you, and why would I, all the different organisms we find on the skin. There are many, many, many different sorts of organisms, but this is one that it used to be said Staphylococcus epidermidis was an irrelevancy. It used to be said that if you find Staph aureus, you've got a disease going on. If you find Staphylococcus epidermidis, it's a contaminant. We don't look at it that way anymore. If you isolate Staphylococcus epidermidis from a patient, you consider there's an opportunistic infection going on, but you have to be careful, because your skin surfaces are covered in this thing. So if you go through the skin, for example, to take a sample, you could contaminate the blood sample by just puncturing the skin and getting Staphylococcus epidermidis in the sample. So you have to be careful in interpreting things in these situations, but it is considered an opportunistic infection. Less common than Staph aureus, and it's obvious why, because everything we said about, not everything, but almost everything we said about Staphylococcus aureus does not apply to Staphylococcus epidermidis. No protein A, no alpha, beta, gamma, delta toxins, no protein A. Anything you care to think about, we said about Staphylococcus aureus as possible pathogenesis factors, doesn't happen with Staphylococcus epidermidis. And I also remind you here that this is an opportunist we're talking about here, not a primary human pathogen, except in some weird instances like toxic shock syndrome or scalded baby situations. We are still talking about pathogenesis factors. So when you talk about a pathogenesis factor, it doesn't mean you only talk about it as regards pathogens. Okay? All right, so that, in this instance, it particularly, Staphylococcus epidermidis, for some unknown reason, has a particular predilection for artificial heart valves and artificial joints. I'm not sure that makes much of a difference when if you've got an infection of somebody's joint and you isolate a Staphylococcus, you've got a problem there. You've got septic arthritis. But this seems to have much more of a tendency, as opposed to Staphylococcus aureus, which infects even if there isn't an artificial joint there. And again, we're talking about the predilection among these opportunists to have differing degrees of pathogenicity, even though they're opportunists. Staph aureus is being more pathogenic than Staphylococcus epidermidis. Identification, again, we should contrast it to that slide here. The exact opposite. Staphylococcus epidermidis is non-hemolytic on sheep blood agar. It is not usually pigmented. It produces white colonies. And here's an example of serum with the plasma, with the pH indicator present. This organism does not ferment mannitol, and so the media would remain pink, and you don't see any coagulation going on there, because it doesn't produce a coagulase. Okay, so again, anytime you think about Staphylococcus aureus, usually think it doesn't have it in Staphylococcus epidermidis, and the opposite happens. This was more recently recognized, and I particularly mentioned about there are not many gram-positive organisms that produce urinary tract infections in high incidence. None of them produce it in high incidence. I mentioned the enterococci, and this is even less common, but Staphylococcus saprophyticus is a particular strain of Staphylococcus that occasionally causes urinary tract infections. Now, the point I want to make, a term that you're going to see a lot when you talk about the Staphylococci, is coagulase positive versus coagulase negative, referring to that test. Very few clinical laboratories, unless they happen to be specialists on this particular situation, you don't differentiate Staphylococcus saprophyticus from Staphylococcus epidermidis. This is what's going to happen in both. The issue comes down to is that if you've got a urinary tract infection, you've got a good chance that it's caused by Staphylococcus saprophyticus, or if you've got, for example, an infection of a hip joint, then you've got more likely, it'll be more like an artificial hip joint, it'll be more likely to be Staphylococcus epidermidis. So you don't usually differentiate Staphylococcus epidermidis, which is the vast bulk of them, from Staphylococcus saprophyticus or other species of Staphylococcus, and they're generally the term that you use is coagulase negative Staphylococci versus coagulase positive Staphylococci. Staph aureus being coagulase positive, and Staphylococcus epidermidis, Staphylococcus saprophyticus, or any other Staphylococcus you're going to come across is usually coagulase negative. Okay, I've actually finally broken the bullet here, and this next year for next year's class, I finally put another bracket in there. I think you should have that down. Many of you have probably come across the term MRSA before, and I hate abbreviations, but it's so commonly used in this clinically. Unfortunately, this is one of the organisms that's becoming a problem. Not becoming a problem, has become a problem, is a problem. The organisms are often resistant to penicillin. Staphylococcus aureus I'm talking about are often resistant to penicillin. The second line drug that was used for many years was methicillin. And unfortunately, many of the Staphylococci nowadays are resistant to methicillin. I don't make a big deal about the Enterobacteriaceae because there's just so much diversity what you can say about antibiotics. But the problem is here is that we're almost exhausted the supply. Many of these organisms are resistant to methicillin, so they're referred to as MRSA, methicillin-resistant Staph aureus, MRSA. I won't put that in the exam. I just meant you want to add it to your notes so that maybe the term might be used on the boards. It's not in the handout. MRSA, okay, methicillin-resistant Staph aureus. The problem is that vancomycin, I mentioned already, has been shown to be antibiotic resistance in the Enterococci. I don't think there's been any vancomycin resistance shown yet in Staph aureus. The concern is that since we're almost getting to the end of the road as to what we can treat staphylococcal infections with, if we happen to find any Staph aureus out there that are also resistant to vancomycin, which is currently the drug of choice, then we're going to have a big problem. And we've already seen that big problem in New York with the homeless people up there who were infected with multiple drug resistance to tuberculosis that we'll probably talk about later. So that's the reason I'm emphasizing this antibiotic situation here, because there's a big problem here, and it is one of the really big problems in infectious diseases at the moment. Now, this was put together, an earlier version of this, by medical students, and you can blame one of your own class from about 20 years ago for this. Actually, I think it's rather nice. About 20 years ago, and Richard Hunt redrew it. I've never actually got around to redrawing it. But basically, this is a summary of how you can tell the difference between the different Staphylococci and Streptococcus. So what I suggest you do is go through the handout, go through the PowerPoint presentation. If you can if you can answer this, you know the answer to this, then you've got most of the actual differential microbial identification down among the Streptococci and Staphylococci. To just reiterate, the first thing you're going to do is a gram stain, then catalase test. If it's catalase negative, it's probably a Streptococcus. If it's catalase positive, it's probably a Staphylococcus. We're comparing clusters versus chains, although we already have an exception down here with the pneumococcus. Then you would look at the hemolysis reactions if it's the Streptococcus in particular. Beta, Streptococcus pyogenes, the CAMP reaction, or Streptococcus agalacti, the group B Streptococcus. We talked about the bile test or optogen sensitivity, Streptococcus pneumoniae. The bile test for group D, and then differentiating the Enterococcus from the non-Enterococcus. Among the Staphylococci, that really should say Staph aureus or anything that isn't Staph aureus, not just Staph epidermidis. If they're coagulase positive, they're Staph aureus. If they're coagulase negative, they're generally Staphylococcus epidermidis or something else, but they're certainly not Staph aureus. Okay, so I think that's a pretty useful scheme. So use that to test yourself when you've been over the lectures. Okay, I'll be happy to answer any questions. I'll stick around for a couple of minutes. If nobody comes over, I'm going to disappear.